Good morning, everybody. My name is Mark Wayne, and I'm the moderator for this session. You are in session 17, and this is breakout room 2. Just a couple housekeeping items before we get started with our presentation. First off, I have posted a pre-test survey link in the chat area, so please take the time to complete that. During the presentation, I'll post a post-test survey evaluation link as well, and that information is very helpful for us, so we'd appreciate you taking the time to complete those. Also, during the presentation, if you have questions, feel free to put them into the chat. At the end of the session, I'll make sure that I get those questions to Anne Wagner, and she will respond to them. And if we run out of time, we'll get that information out to folks. So I think before we get started, I'm just going to go ahead and introduce our speaker and provide her bio. So today our topic is frostbite in January, amputation in July, and Dr. Anne Wagner is presenting this. Dr. Wagner completed her undergraduate degree in 1995 at NDSU in Fargo, North Dakota, and her MD training in 1999 at the University of North Dakota School of Medicine and Health Sciences in Grand Forks, North Dakota. She completed her surgical residency, critical care fellowship, and a burn fellowship at Hennepin County Medical Center in Minneapolis, Minnesota. She is currently an associate professor of surgery at the University of Colorado School of Medicine. She is also the medical director of the Burn Center at the University of Colorado Hospital. She has multiple publications, abstracts, poster presentations, and many ongoing research studies with a focus on evidence-based care of frostbite patients. She is on the research committee for the American Burn Association and is recognized as a national expert in the field of frostbite. She has given over 129 invited lectures and presentations throughout the country. This presenter has indicated that this presentation will not include discussion of any commercial products or services and will not include any discussion of off-label and/or investigational uses of any product or services and will not include trade names. So with that, I'll turn it over to Dr. Anne Wagner for her presentation.
Good morning, and thank you guys for inviting me and having me participate in the conference. I'm very excited about that. I do go out and present all over about a 7-state region from Montana down to New Mexico, and I love to include pictures of my home state, North Dakota. I throw in as much North Dakota information as I can. For those of you that are from the eastern part of the state, you will recognize this picture. This is right outside of West Fargo. And why the title of the talk? The old adage is that you would get frostbite in January when it was one of the coldest months of the year, and then you just left it alone until it demarcated and ended up with either a self-amputation or a surgical amputation in July. We're going to go over what the acute care of the frostbite patient is from an evidence-based focus, and we'll discuss new and ongoing research and how we kind of got to where we are. I don't have any financial relationships or anything. This, by the way, I'm from Castleton, North Dakota. This is the can pile, which was pretty much our only monument to speak of. The burn center I work at opened in 1978. It has 19 beds, and currently we're admitting a little over 550 patients a year. This is a picture of the burn team, and while you look at these people, realize they come from all over the Midwest as well as Colorado, from all different disciplines. Taking care of burn patients requires a big team of people that are very specifically trained in the care of the burn patients. You can see my operating room staff, my physical and occupational therapy staff. I have a lot of nurse practitioners and PAs, my dietitian, my nursing staff. In addition to that, we have our own social worker, case manager, psychologist, chaplain, the list pretty much goes on and on. This is the states that we cover. And as you can see, I do a lot of traveling to make sure that we are able to educate the whole region that we cover. A lot of people think that we pretty much only take care of frostbite or burns, but we take care of lots of other things. You could see up on the left, that's a ferning sign. This is a young man who got hit by lightning and who did great, by the way, and what he looked like the next day. We take care of significant degloving injuries, chemical injuries, child and adult abuse, different exfoliative skin disorders. You can see scalded skin syndrome up in the top left, toxic epidermal necrolysis in the bottom, significant road rash, and we do reconstruction for patients that have necrotizing or soft tissue infections. Starting with frostbite and how we got to where we are today, Bill Mills, who was a physician up in Alaska, was the first one to actually start looking into frostbite and what could we do to make things better. And really at that time, and this was in the 60s, what he was able to find was that rapid rewarming definitely helped to limit the amount of damage to the tissues. And so it was at that point that we kind of stopped the thing where you would just slowly rewarm them by putting them in cold water and then gradually and change to rapid rewarming. We'll talk a little bit more about that later on. From 1961 until the 80s, really not much more was known about frostbite. In the 1980s, a man named Dr. Martin Robeson, who is a very good friend of mine, was a burn director in Chicago. It was a very cold winter. Chicago decided to shut down the L train, and he, in one evening, got over 40 frostbite admissions, which is huge for any burn center to take care of. It was frustrating, and it even is to this day when you can't fix things. I think we always want to fix things and make people better and keep them as intact as we can. And so he started studying what was in the blister fluid of frostbite. And he found that there were two inflammatory markers that were really elevated. It was prostaglandin F2 alpha and thromboxane A2. What these two do is they cause a lot of ischemia, causing the vessels to constrict and cause a lot of pain. Because of this, and because these inflammatory mediators are formed through the arachidonic cascade, he looked into developing a supportive protocol that would hopefully help these patients do better. And that protocol include immediately putting patients on scheduled ibuprofen to block the arachidonic acid cascade. He also used aloe vera as a topical to treat the wounds due to the fact that aloe vera from an external blocks thromboxane A2, and then the ibuprofen blocks those inflammatory mediators from the inside. You can see what he found by using this protocol, that he had a very improved outcome as far as tissue loss, the morbidity, and he was able to significantly decrease length of stay. He also found during his studies that doing super active and aggressive debridement of hemorrhagic blisters led to greater morbidity and a higher rate of amputations. We go then almost another 20 years before much is known to improve the outcomes in frostbite patients. And this was kind of happening while I was a resident at Hennepin County. And my mentor, Dr. John Toomey, who was the man that started the burn center at Hennepin County, started looking at the use of thrombolytics. Obviously, at this point, we were using thrombolytics for heart attack and stroke. And we knew that one of the biggest things we were fighting with frostbite patients was the thrombotic complications that happened from that inflammatory response. So he got an IRB and started an off-label study looking at the use of thrombolytics in patients with severe frostbite. He initially started doing his study using directed intraarterial alteplase, and then found that he was getting quite a few complications from that. It was leading to a lot of hematomas and things like that at the site of the catheter. And it also was kind of delayed the treatment because he had to wait to get radiology to come in. He then switched over to intravenous IV thrombolytics due to the fact that he knew that that worked for heart attack and stroke once again. And he found out that actually he got the same results and actually even a little bit better because less complications. You can see that the pictures in the patient that you see in the picture in his experience, they ended up with an amputation between 70 to 80% of the time. He used some alteplase on this patient. You can see that he fully healed his fingers. He was able to decrease his amputation rate in these patients from that 70 to 90% down to a 19% amputation rate, which was a significant improvement at that time. The radiology pictures you see are a triple phase bone scan. This is still the standard of care for evaluating how significant and how bad the injury is to those extremities. You can see in the one picture there is no evidence of any finger perfusion. There's a cutoff. In the picture next to it, that's that same gentleman after he was given thrombolytics. He also found that when he used thrombolytics, patients that had been outside or had been frozen for more than 24 hours didn't have as good of outcomes. Also, if they had been warmed and the tissue had been ischemic for more than 6 hours, they didn't do as well. Patients that came in with freeze-thaw freeze cycles, which happens a lot in the urban areas, did not really have any response at all to the thrombolytic. But at the end of the study, found out that it was very safe and effective. This was published in the Journal of Trauma in 2005. I initially graduated from Hennepin County and went across the river and was a trauma surgeon in St. Paul. I loved burn. There are a very limited number of burn centers. And after about 5 years, I was invited to come back to Hennepin and do a burn fellowship and help to eventually take over the burn unit there. The first thing that happens whenever you get a new job is you're always asked to basically update the protocols, the policies, develop new order sets. And one of the first things that I started looking into because of my interest in frostbite was what our protocol and our order set looked like for frostbite. The thing that I was most interested in, and I really couldn't find it by looking through the literature at that time, was how far out was too far out. Could you still give TPA at 12 hours, 24, 48 hours? Would it still be effective? I had a couple outcomes from the study of this, and one of them was we developed this quantification score. There wasn't a really good way to quantify the frostbite injury so that you could actually study it and know if you were making things better. So this was the first paper that came out that we, of all the patients that I pulled the numbers on, we studied their bone scans and looking at the bone scans and looking at the numbering system you can see on the screen, you would then get a number for how much tissue was involved. You could then treat them and then look at the number after treatment and see if you were able to make a significant improvement. The second part of the study, as I stated, I wanted to know about time. How much did time matter and how far out could we go? And you can see that I was actually fairly surprised to find that there's almost a 30% decrease there's a 30% decrease in salvage rates for every hour after that tissue has been rewarmed. And this was found to be significant, as you can see in this paper, which was published in 2017. About the time that this paper was coming out, I actually interviewed and was given the job at the University of Colorado. I wanted to, again, for a new guy in the door, you get to study and look at all the protocols and policies and see what you can do. I again started with frostbite, wanted to see where they were at. I had shared the frostbite protocol that we had been working on with Dr. Toomey and then with further development with Colorado a couple of years before I came. So I had a few years of time that I could study and see how we were doing. So you can see that I looked at patients from 2013 to 2017. That was 123 patients. And when looking below, what really struck me is 32 patients were able to get the TPA at the university with that number of digits affected. 45 patients had contraindications and were not candidates for TPA, but an equal number of patients didn't get TPA just due to the fact that they arrived more than 24 hours out after their extremities had been rewarmed. So this brought to mind, well, I had thought about this actually in Minnesota because I care of patients from North Dakota, South Dakota, Iowa, and a big surrounding region again. Was there a reason why we couldn't safely start TPA at the outside hospital? Could we do it effectively? Could we do it safely? And what would this do to our amputation rates? So I started and you can see this gentleman in the screen. His name is Dr. Scott Gallagher, and he's an ED physician working up in Aspen. I get invited to lots of areas in the country to give frostbite talks, and Aspen had invited me up there, and Scott was there, and he said, well, I'd like to work with you to develop this remote protocol. So we looked at how things worked. It would work best in a small ED. I did lots and lots of education to all of our referring areas. And then we started using this protocol remotely. And of course, following this, I wanted to then study the outcomes and see what we had learned from this experience. So this paper, by the way, has just been published and came out a couple months ago. So I reviewed frostbite patients from 2015 to 2020 when we implemented the remote frostbite protocol. Severe frostbite is defined as patients that have 3rd and 4th degree frostbite, and we'll talk about what that is in a little bit. We excluded patients that had frostbite in other locations because it's actually a completely different process. And we also excluded patients that we didn't find out what their final outcome was. So we really wanted to be very exact and know how patients ended up after they got their TPA. Looking at the demographics, and this unfortunately there is a very, very large homeless population in Denver. It surprised me when I first came here. I come from a town of 1,500 people, and there are more than 10,000 homeless people in Denver, Colorado that live in these communities along many of the roads. And so you can see in these patients that I took care of, over 50% were homeless, 40% had chronic alcohol use. Marijuana is humongous out here. That was an eye-opening experience for me, not really used much up in North Dakota, Minnesota. Other drugs of abuse, there is a huge meth and heroin population here. A lot of these folks use cigarettes, and there's a very high degree of mental illness, especially in our homeless population. So this is kind of what we found out. So you can see on the one is the TPA that when patients got it remotely or prior to coming to us, pre-transfer. You can see the numbers that required major and minor amputations that got TPA on arrival to the university. And then you can see what it looked like for those patients that did not get TPA due to contraindications. So basically, of all these numbers, although there's definitely it is leaning that direction, the only pre-transfer or remote TPA had a significant improvement in amputation rates. This, by the way, was the largest frostbite study published to date. If you look up information on frostbite, there's a lot of people that will talk about how they do it. There's not a lot of talk or real legitimate studies that are comparing outcomes based on the treatments that they're getting. And most of the studies that you'll look up, you'll be lucky if they include 25 to 50 patients. So the fact that we were able to include almost 200 patients made this a very, I felt like a much more legitimate study. You can see the number of patients that got TPA before coming, TPA at the university, and those that did not get TPA. The patients that didn't get TPA, some of this I guess is not super surprising. Patients that were older, I'm not sure why that was. Patients that were homeless. What we find here in Denver and in the surrounding area and states is the homeless population oftentimes won't show up until they've had the frostbite for even up to a week, and they have gone through multiple freeze-thaw, freeze cycles. Patients that got TPA were less likely to be acutely intoxicated with one of the drugs of abuse that we described. The conclusion of this study was that we saw that patients that got TPA prior to transfer had the lowest risk of amputation. Comparing patients who got an amputation to patients who did not, the patients who did not, the significance was found in patients who did not get an amputation primarily due to late presentation were homeless, used a lot of marijuana, and had a much larger modified Hennepin score. So I talked a little earlier about the Hennepin score, which is based on a triple phase bone scan. We still do get triple phase bone scans to evaluate how much tissue is damaged, but we do not hold up giving the TPA to get that bone scan, which is very difficult to get in most areas and including here at the university. So we use a modified score, which means we're using a visual score of patients that come in with first through fourth degree frostbite. So that's the modification, is it's visual instead of being based on triple phase bone scans. We found that it was a very safe protocol. We had 2 adverse bleeding events. One required transfusion. This patient was a woman who was involved in a motor vehicle accident out in the mountains in a remote area. She got out of her car, ran around in the snow for over an hour, and then went back to the car and passed out and was found. There are rules for who you can start TPA in, especially if they're intoxicated or have been in an accident. She had a full trauma workup, including CT scans of her head, chest, abdomen, and a very small hairline fracture was missed in her pelvis. This hairline fracture created a hematoma, requiring her to get a unit of blood. The other patient who had an issue, didn't really have an issue with the TPA, but initially was started on TPA even though the patient was intoxicated and had a positive head CT. It was immediately stopped as soon as we found out that had happened, and this patient went on to have a complete recovery from his head injury. We also found that patients that receive TPA remotely or on admission have a much lower risk of amputation compared to no TPA, and you can see that that's significant. This is a case that, and I don't want you to think that this is like more extreme than other cases that we see. This patient actually showed up in Aspen, where Dr. Gallagher, the man I talked about earlier, was working. This is a 56-year-old gentleman who was found down in a creek after doing a lot of heavy drinking and marijuana use in the winter up in Aspen. He came to the ED with minor abrasions. He did not have any significant external trauma, and he underwent the full workup that we talked about, including a head, chest, and abdominal CT, making sure those CTs are read by a radiologist, and he also went through rapid rewarming. He then had the remote TPA protocol at that hospital and was sent to us basically over the mountain through the woods. Aspen is several hours away from Denver itself. This is what his feet looked like before. And if you look at the top pictures, that's what his feet looked like when he got to us. So it's really even hard to tell at this point that he had a frostbite injury. You can see the abrasions on the top, especially of the left foot that we discussed earlier. Those were from him being down in that cold water with his bare feet. Those obviously healed up really well, and we had no difficulties with any bleeding due to those while he got his TPA. As I stated, we get a bone scan after the TPA is given to see how well that patient responded to the TPA. And you can see by looking at this picture, he has full perfusion of all his toes. The little dots that you see on his feet are to indicate where the tips of his toes are. Just to show you what our experience has been ongoing. Every winter is a little different just like it is back in North Dakota. In the 2018 to 19 season, we had 58 frostbite admissions. We gave TPA 20 times, and of those 20, about half of them were started at the outside hospital. This lady was included. This was an unfortunate homeless lady living in her car. She presented to a hospital down in Colorado Springs. They actually didn't know about the remote protocol. We went through it with them. We educated them on it. They did the full workup with her. She got TPA, and as you can see, her feet had a complete recovery. Season 2019 to 2020, now you're starting to see the TPAs being given more and more starting it at the outside hospital. 40 frostbite admissions gave TPA 12 times, with 10 of those started at the outside hospital. Once again, you can see the purple discoloration in the patchy thrombosis on the top of his feet. It initially does not, when you first see frostbite, after you rewarmed it, it will not initially be black like you saw in that one picture. It kind of develops over time. So in this gentleman, this is more of an earlier picture after rewarming. This is probably about an hour after rewarming where he's starting to get that demarcation. And then once again, you can see what his feet look like after rewarming. He had complete resolution and he has a great bone scan at the bottom. This is our season this year. It's been a tough winter. It seemed a lot more like North Dakota here this year than it did like Denver, which is really very temperate. We don't get a lot of snow in Denver, but we had over 81 frostbite admissions this year. We administered TPA 26 times, and 24 of those, so almost, over 90% of them were started at outside hospitals. This is another example. You can see the purple on this gentleman's ankle and on his toe, and that's completely gone after getting the TPA started at the outside hospital and coming to us. Once again, a great looking bone scan. I then went on to study, I wanted to know how, because it's very, very significant here, the amount of drugs of abuse it's actually almost gotten to the point where I'm kind of happy when somebody comes in and they're just your run-of-the-mill alcohol user. I see a lot more people that are addicted to meth or opioids, and everybody here seems to think marijuana does not cause problems. So we knew in burn patients that the use of alcohol has been associated with an increased risk of infectious complications. It also increases their length of stay, the days they're on a vent. It increases their ICU length of stay. They also have a higher mortality rate. So 3 times the rate of non-alcoholics, and smaller burns die when they come in as a chronic alcoholic than those that have bigger burns without alcoholism as a diagnosis. They also require a lot more fluids to get them fully resuscitated. And you can see it's about 3 times as much fluid required for somebody who is positive for alcohol when they show up. So I studied it in the frostbite population. I wanted to know, and there had been some talk about, well, we think marijuana might be protective. And I'll be honest with you, I did not think that that could be a possibility. And you probably saw in that recent study that marijuana was actually significantly associated with patients that got more often got amputations. So in this study, I once again looked at 140 patients, wanted to see, the big thing that I was looking at was amputation rates. We studied positive toxicology screens, homelessness, mental illness, and who did and did not get TPA. By the way, looking at this picture, this is one of our unfortunate homeless folks. We do a lot of work with the, there are some homeless clinics here in town. We work very closely with them to help educate them, and they actually go out and educate the homeless population. In addition, every year we raise a lot of donations and money to take warm clothing out to the homeless, including hats, coats, boots, socks, tents, sleeping bags, whatever we can do to help prevent these injuries. So these are the demographics we can see, and you can see once again, very high rate of mental illness with patients that were positive for frostbite and drugs of abuse, a lot of homeless folks, a lot of these guys, once again, using tobacco, alcohol, and marijuana. So what we found out that that these drugs, tobacco, and homelessness significantly impact clinical outcomes in frostbite patients, sometimes because of when they show up, as well as other things. Unlike the fact that in burns, alcohol has a strong association with poorer outcomes, it does not have that association in the frostbite patients. These patients use a significantly a significant amount of hospital resources. We do not discharge homeless patients to the street. So they will end up living with us sometimes for months as we are looking for placement for them, allowing them to heal, and et cetera. And there is a fairly high rate of recidivism in this population. So we see folks that come back year by year, even though we do try to get them out of situation. Looking at frostbite, I talked about the fact that there are different degrees of frostbite. First degree frostbite is where you just see a slightly purple discoloration. This does go all the way through the epithelium, and it will hurt a lot, but it does not. They heal perfectly. Second degree, you can see these clear fluid-filled blisters on this gentleman's toes. That is a second degree frostbite injury. Once again, this will heal on its own, just like a second degree burn. We will recommend that you unroof those hard, taut, clear serosanguinous blisters completely and treat these wounds with topical aloe vera. We put that on 3 times a day. The bottom picture and the bottom 2, third and fourth degree, are what are termed severe frostbite. So severe frostbite means that the injury goes through the epithelium, can go through the epithelium, the dermis, may involve muscle tissue, as well as all the way through the bone when they've fully frozen the end of their extremity. They will develop a hemorrhagic blister due to this deep injury. These are the blisters I talked about a little bit earlier that you don't want to debride. It's better to leave them intact. What we have found with debridement of these hemorrhagic blisters, that the patient's the wound desiccates. It also leads to increased tissue or increased infection rate. And frankly, it's very difficult to tell where dead tissue stops and live tissue starts, because it may have some dark discoloration. So we do not recommend aggressive debridement of these blisters for some time when the patients present to us. So patients that have an indication for getting TPA are those that come in with severe frostbite, the third or fourth degree frostbite. Frostbite patients do better working at or going to a hospital that is used to taking care of frostbite. There is more to frostbite than TPA. There's a lot of supportive measures that we take. There is a specialty of the physical and occupational therapists, what kind of shoes they wear, when do they get up and walk on those feet. There's lots of other things. Even the surgical management of these patients is a little bit complicated. We always recommend rapid rewarming. This is a gentleman, you can see that his feet are being rapidly rewarmed in an emergency department. We prefer, if you can, to use circulating water so that the warm water is, as it's getting cold around those cold frozen extremities, you're rewarming it and keeping it warm so that they warm up very quickly. We generally recommend keeping the water around 104 degrees. If you get much warmer than that, they have a lot of pain with rewarming, and you don't want to get too warm because they can actually get a burn on top of that. It takes about 30 to 45 minutes to rewarm an extremity, be it a foot or a hand. Now, if the patient presents to you and has a boot that is frozen to them, which happens, or a glove, we do not recommend that you try to take that off, or things like a ring. You need to dunk that whole thing, the boot and the foot, into this warm water and let it go until literally the boot is completely unthawed from that extremity, and then continue to rewarm them. In these cases, those will take a lot longer to rewarm, and it just depends on what they're wearing on that extremity when they come in to see you. We then do recommend air drying it. It's a very painful injury. You don't want to do a lot of aggressive manipulation. Those tissues are very tenuous at that point. So you want to elevate them to decrease swelling and put a bulky padded dressing on them. This protocol, by the way, I share this very willingly with anyone who is interested, and I will give you more information at the end on how to get it. So we will administer the protocol if it's within 24 hours of the time when they were rewarmed. You need to rule out associated trauma, as I talked about earlier, as far as looking for any internal issues, getting a head, chest, and abdominal CT. We will pretty routinely get a head CT on our homeless population. There is a lot of violence that happens out on the street, so we want to make sure they're not walking around with occult subdural hematoma. If they have lacerations, that does not mean they cannot get, they've had no problems. Once those lacerations are repaired, they do just fine getting the TPA. You need an accurate weight, not an estimated weight. The loading dose is 0.15 milligram per kilogram. So for instance, in your typical 70 kilo guy, I believe that comes out to 10.5 milligrams that you will bolus over 1 to 2 minutes. Following this, you start a drip. 0.15 milligram per kilogram per hour, which once again would be about 10.5 milligrams in that 70 kilo person. So they'll get that dose each hour times 6 hours. Now for folks that are bigger, and when you hit about 94 kilos, it will take more than 100 milligrams to complete that course. So we stop at 100 milligrams. These patients, just like your heart attack or stroke patients, are ICU status while they're getting the thrombolytic and have ICU status monitoring. Immediately before or after turning off the TPA, we start them on treatment dose Lovenox. The feeling, and we all feel this is probably true, that you need to keep them anticoagulated because there still is a lot of damage to the endothelium, which will then cause ongoing thrombosis, and things will start to basically clot up again if you don't keep them anticoagulated. This, by the way, is just another example of a very light-skinned person. That's what his toes looked like a couple hours after rewarming, so it is very subtle. When you look at his bone scan, which was done prior to him getting TPA, he has complete cutoff of all of those toes on that foot. Had he not gotten TPA, he ran about a 90% chance of ending up with a transmetatarsal amputation. Absolute contraindications are those patients that have the extremity has been warm for more than 24 hours. We do not give it to anybody who goes through a freeze-thaw-freeze cycle, if they've had a recent head CT, any trauma internally with active bleeding that obviously you can't take care of tamponade. If they cannot follow a neurologic exam, and this can be due to dementia, intubation and sedation, we will not give TPA because we can't follow that neural exam. And if you cannot control severe hypertension. Some relative things, as you can see, are on the sheet there, things to use caution with. Some of our older folks will, once again, they can bump their head and walk around with an occult subdural. We will frequently run them through and get a head CT before we restart it. You can see some of the other things. Some of these definitely I wouldn't give TPA for, but you have to really think about it, talk with the patient, and then document what you talked about. For those patients that come to us outside of 24 hours, we do our supportive frostbite protocol, which means keeping them non-weight bearing until they have significant healing. Now, that doesn't mean they can't get up and walk, but what it does mean is we need to put them in special shoes, etc., to keep them off that damaged tissue. We use aloe vera, which ours is just called Dermade, which is simply aloe vera 100% with some lotion in it. If you use 100% aloe vera, it can burn. It's got a lower pH. So that's the only reason we use something a little different. We completely unroof or deroof any serous or serosanguinous blisters to get rid of that those inflammatory mediators, and due to the fact it causes a lot of pain and tissue ischemia. We do get a bone scan to assess involvement in these patients. It will tell us and indicate those patients that are most likely going to require an amputation. If it does look like they're going to require an amputation, we often will consult our physical medicine and rehab doctors. In addition, we will talk to prostheticians so they can come in and talk with the patient to discuss what their options will be. And physical and occupational therapy stay involved with these patients, all of these patients, for quite some time. Looking at future directions, this is, I hope it'll work. This is a video that was played during the Super Bowl. My husband was able to capture this for me.
How bad is it?
It's not good. I'm afraid it's called the Frostbite. We're gonna have to amputate.
Wait, let's talk about this.
So I guess what I'm trying to point out to that is we have better things that we can do for frostbite than amputation. I'm very proud of being from North Dakota. I use famous North Dakotans as people that were the future directions for later in life. And I always ask, can people get a little prize if they can pick who this is a picture of? And of course, I know who it's a picture of because I have his jersey. In fact, I have two of them. And I suppose many of you guys recognize him as Jimmy Kleinsasser, who was the future direction for the Minnesota Vikings. Interesting enough, about 3 weeks ago, I was walking in downtown Denver to get my hair cut, saw a purple jersey in the window of a vintage record store, ran in, and sure enough, it was Jimmy Kleinsasser's jersey, which you may or may not know, they're very difficult to get. So I was pretty excited. Things we're looking at is whether or not hyperbaric medicine could help out these injuries. It increases the formability of the red blood cells so they can fit through those tight damaged vessels more easily, gets rid of tissue edema, and makes little teeny nutritive capillaries throughout that area just with a 90-minute dive, so that tissues that's not being perfused will start building up blood vessels. It improves oxygenation for those damaged tissues so that they are able to heal better, and it completely reverses that reperfusion injury and those inflammatory mediators that we talked about. As I stated, I trained at Hennepin County. They have always had a big hyperbaric chamber, and I think for most of us, we never really realize until we're not there anymore that not everybody has it, but that's kind of what it looks like. My interest started when I read this article. I didn't really know at first if it was really helpful. And you can see with this patient, she suffered severe frostbite to all 10 fingers. 2 weeks after getting discharged from the hospital, started hyperbaric oxygen and was able to fully heal her fingers. Other things I'm looking at are dosing and redosing of the thrombolytics, looking at how accurate an ultrasound machine is to diagnose the frostbite when it comes into the ED. And I continue to review the amputation rates of these patients. Some take-home points: rapid rewarming is the preferred method to get these tissues rewarmed. Be careful that they are in something so they're not knocking against the sides of whatever you're able to use to rewarm them. Patients that have undergone trauma in conjunction with frostbite are not an absolute contraindication. You just have to work them up and determine what the risk is. Starting TPA at the outside hospital has significantly improved outcomes, and patients that get TPA will do better at a hospital that takes care of patients that have frostbite and has experience with it. This is my email address. You can email me at any time. I will be happy to answer any questions, and I will freely share my protocol if you're interested in having it. I appreciate all of you listening to my presentation. Thanks for asking.
I don't see any questions out there, but certainly appreciate your time today. Thank you, Anne.